Welcome, colleagues. We're all seeing more patients with mild primary hyperparathyroidism, but fewer of the classic bones, stones, and groans. So what's our move? We're going to dive into 3 really interesting clinical cases that show us exactly what subtle but critical clues we need to be looking for. So here's the plan. We'll do a quick refresher on the different flavors of PHPT, then we'll walk through our 3 clinical puzzles, and we'll finish up with the key management principles you can apply in your own practice. All right, let's jump in. The main challenge we're facing now is that routine lab work catches so many cases of primary hyperparathyroidism early. This means most presentations are asymptomatic, which, makes our job a lot more nuanced than it used to be. Getting the diagnosis right really comes down to precision. You have your classic hypercalcemic PHPT, high calcium, high or inappropriately normal PTH. Straightforward. But then there's this other beast, normocalcemic PHPT, or NPHPT. With this one, the calcium is normal, but the PTH is high. The absolute key here is that you can only make this diagnosis after you have painstakingly ruled out every other possible secondary cause.
Okay, let's see how this works in the real world with our first case.
So our first patient is a 52-year-old postmenopausal woman. Her PCP flags an incidental high serum calcium. She reports feeling a bit of fatigue, but that's it. No fractures, no kidney stones. Seems pretty simple on the surface, right? Well, her labs come back and confirm that mild hypercalcemia. Her PTH is sitting right at the tippy top of the normal range. But here's the detail that changes everything. Her 24-hour urinary calcium is 300 milligrams. That number is the whole story. Now, we know she's only 52 and her DXA scan doesn't show osteoporosis. So based on this data, what's the one thing that pushes us towards surgery, even though she's otherwise asymptomatic? The answer is B. It's all in the urine. This case is a perfect reminder that asymptomatic absolutely does not mean no risk. That significant hypercalciuria is a direct, standalone indication for surgery. Why? To prevent future kidney damage. It's not her age pushing us to the OR. It's this undeniable biochemical risk factor. And look, this isn't just a clinical hunch. It's spelled out plain as day in the 2022 guidelines. They explicitly list significant hypercalciuria as a key reason for surgery. This just confirms that her lab value isn't just a number. It's a clear signal to intervene.
Okay, on to our second case. This one introduces a really common curveball in endocrinology, one that we have to think about carefully.
So this time we have a 30-year-old woman. She has a 10-year history of taking lithium for bipolar disorder, and she's been sent to us for hypercalcemia. Right away, that medication history should be the #1 thing on our minds. It's the central clue.
Her labs are pretty striking. Serum calcium is up at 11, and her PTH is 120. If you just looked at these numbers in a vacuum, you'd say, yep, that's classic primary hyperparathyroidism. But knowing her full story, what's the diagnosis that really puts all the pieces of the puzzle together?
The answer is C, and the key, of course, is the lithium. It directly messes with the calcium-sensing receptor, shifting the PTH set point. What does that mean? It means her body starts to think a higher calcium level is normal before it bothers to suppress PTH. It's a perfect biochemical mimic of PHPT. Now, we don't know if the lithium is causing this or just unmasking it, and that's exactly why we don't rush to surgery. The right move is to collaborate with her psychiatrist. Let's see if an alternative therapy makes the hypercalcemia disappear. All right, our final case. This one gets into what might be the trickiest diagnosis in this whole area. Normocalcemic primary hyperparathyroidism, NCPPH. Here we've got a 60-year-old woman who we already know has osteoporosis. But the plot thickens. An ultrasound for something else incidentally spots a nodule that looks like a parathyroid adenoma. So we have imaging pointing to an adenoma. The question is, what do her labs?
When you look at her labs over several months, it's a confusing picture. Her serum calcium stays stubbornly normal, but her PTH is bouncing around, sometimes elevated, and then you see her 24-hour urinary calcium, a whopping 408 milligrams. This is a real diagnostic conundrum.
So you've got this fluctuating biochemical picture. You've got sky-high urinary calcium, known osteoporosis, and an adenoma on a scan. How on earth do you classify this? The best answer here is D. This is a fantastic case of normocalcemic PHPT that is clearly starting to regress. Her normal calcium with high PTH fits the NPHPT definition perfectly, especially since we know secondary causes were ruled out. But that high urinary calcium and the osteoporosis, those are undeniable signs of end organ damage. This really drives home a key point. NPHPT isn't always a quiet condition. It can be the first step towards the classic full-blown hypercalcemic disease.
Okay, let's pull all of this together. What are the big picture principles we can take away from these three very different cases?
If there's one thread connecting all these cases, it's this: biochemistry is king. A thorough, guideline-driven workup has to happen before you even think about ordering a scan. It's so important, I'll say it again. Scans localize, they do not diagnose. And when you do land on a diagnosis of NPHPT, remember that watching and waiting is often the right call, unless you see clear proof that the disease is progressing or causing real damage.
And that really brings us to the main challenge, doesn't it? The next time you see asymptomatic hypercalcemia on a patient's chart, how will you approach it? These cases teach us that being relentlessly vigilant for those subtle clues, the high urinary calcium, the confounding medications, that's what elevates a standard workup into a truly excellent diagnosis.